So we're going to talk about responding to requests for parental requests for potentially non-beneficial treatment. A little bit of a caveat that I help write the board exam questions. It was a bit of a loaded question that I've been recently asking people who took the board exam this past week. How was the board exam without actually revealing that fact? I feel like that gets me more kind of straight scoop on how that went. But as I came here, as I flew down a couple of days ago, it reminded me the last time that I was in this neck of the woods. So we were coming out of the COVID pandemic. We were beginning to do in-person meetings again. And there was this wonderful meeting in San Jose at the George Mark House called the Pediatric Palliative Care Summit, rather noble title. And they brought in this amazing panel of speakers. So these are the plenary speakers. I'm at the bottom. The top four are, if you weren't aware, really rock stars in our field. Specifically, I think of Betty Farrell, who I think has probably written more articles than I've read. She's just a remarkable person. And so I got there and I thought to myself, wow, I've arrived. Like if I'm on this panel with these people, that must mean something great about what I was doing. And then the plenary came up, and this was in the bulletin, and I had provided all the materials they had asked for, like my CV and my bio sketch. And I thought to myself, okay, here we go. And then I glanced a little bit more closely, and I saw that underneath my name on the bulletin. And I thought to myself, I don't even know what that is. And I asked my kids, and they're like, that's your Twitter handle. And I said to them, I have four kids. I said, I didn't even know I had a Twitter handle. And they said, yeah, don't you remember? We made you one. So my kids made me my Twitter handle. And clearly, it made it a few years ago. You can tell that I'm not in the running for being a social influencer because I only have 11 followers. But then I said, what exactly did you write? And this is what they wrote for me. And I'll let you all read that. So let's just say my gravitas at this meeting took a big hit when it came to that. So I thought I had arrived. And all of a sudden, I'm thinking of the people in the audience reading that about me. And that I said, well, at least that sufficiently lowered expectations for whatever I was going to say. So with expectations lowered, let's talk about non-beneficial treatment. So non-beneficial treatment can come in several stripes. One are things that have been proven ineffective. Another are situations where it has not been proven effective. Here, remembering that old adage that absence of evidence is not the same as evidence of absence. And lastly, things that are unlikely to provide benefit and potentially may cause harm. And that's what we're going to focus on today. So these are objectives. Anytime you give grand rounds, you have to have objectives for CME purposes. I use action verbs like you're supposed to, but in practicality, kind of reframe the objectives into what we're really going to do this morning. So we're going to talk about how we got here, what we've tried to address this very, very complex topic, why that hasn't worked. We're going to look at some recent consensus recommendations from the adult literature and apply them to pediatrics. We're going to come up with a concrete plan, and then we're also going to look at some extreme cases and how that plan affects those extreme cases, because those are the cases that keep us up at night. All right, so how do we get here? So the notion of futility, I'm going to use that term initially in a more broad sense and soon in a more specific sense. Futility has been around for a very long time, back to the days of Hippocrates, who talked about situations where patients may be overmastered by their diseases and calling upon physicians to not treat those diseases if it's going to be ineffective. But the history of futility from Hippocrates on into the 20th century was basically an acceptance of that from the Hippocratic corpus. And then all of a sudden in the 20th century, it really took off. So before the 20th century, it didn't really have much of play because we were living in a more paternalistic age. We weren't talking about patient autonomy. We weren't really talking about shared decision making. So if there was some treatment that physicians felt was going to be quote unquote futile, we just wouldn't offer it. And in the pre-internet age, patients wouldn't Google something and come up with an idea. So if we didn't mention it, they wouldn't know and there wouldn't be any conflict. But then in the mid 20th century, there was a shift. There was a shift away from paternalism into more respect for patient autonomy, moving into the notion of shared decision making that we work with now. And so it got to the point where in the 1970s, there were some laws passed and some very seminal court cases that allowed patients at that time, for the first time, to say, no, I don't want that treatment you want to give me, even if you think it will help. So gave patients the right to say no, which they really didn't have prior to that. This was called the right to die movement. So patients could say no to what physicians thought they should do. But then the question began to be flipped. Well, patients can say no to what physicians want. Are physicians allowed to say no to what patients want? And that's what became known as the futility movement. The AMA got involved. Their code of ethics started saying things like physicians are not ethically obligated to deliver care that, in their best professional judgment, will not have a reasonable chance of benefiting. And we'll parse reasonable, we'll parse benefiting. And so all of a sudden, the AMA was starting to talk about this. The question, though, is how you instantiate that. What do you do with this concept? How do you put it into practice? And so this futility movement, so called, began in the 1980s. The first reference actually to futility in the medical literature was in 1987. And around that time, there were a lot of position statements that came out from various groups saying, this is what futility is, potentially, and this is how we're going to deal with it. And there was actually even some legislation, which I think is notable. So in 1999, the state of Texas passed this thing called the Texas Advanced Directives Act, or TADA for short. And this was an interesting act because it really put some teeth into these futility policies. The Texas Advanced Directives Act essentially said we're going to empower hospital ethics committees to function in the role of the courts. So they had a very specific process that if the hospitals followed, documenting that they thought a treatment was quote unquote futile, getting a second opinion, seeking transfer to another hospital if possible, working with the family, bringing it before the ethics committee of the hospital, that if the ethics committee at the end of that said, yes, we deem that to be futile, then the patient and family had 10 days in order to find another receiving facility. And if they couldn't, the hospital was legally able to stop that treatment after 10 days without any judicial recourse. So the hospital ethics committee was functioning in the role of the court. So there was a lot of interest in futility during this period of time. As you can see, these are Medline references per year. 1987, first reference to futility in the medical literature. And now all of a sudden we're kind of taking off. This thing that was never talked about is being talked about. But it didn't work. So why didn't it work? I think there are three reasons. One is definitions, another is reasoning backward, and the third is implementation. So let's look at definitions. One of the first articles about futility, published in 1988 in JAMA, has a very interesting sentence. Futility has a variety of meanings, this article said, including the narrow sense, physiologic inefficacy and inability to postpone death, and a broad sense, inability to prolong life for a time, inability to maintain an acceptable quality of life, very low probability of achieving any one of the foregoing. Now, if you parse that, you'll actually find three distinct definitions of futility in that sentence. One is what we would call physiologic futility, physiologic inefficacy and inability to postpone death, but the inefficacy piece is will not achieve its stated goal. An example of that might be CPR in the context of cardiac wall rupture. Another is qualitative, or what some people would call normative futility, which is to say that the procedure may work, but what kind of quality of life is it going to perpetuate? And the last is probabilistic futility, which means low probability of working. So you actually have three different definitions all in one sentence. And when you look at the various position statements that were coming out in the 1980s, these are several. I don't want to get into the details of this, but I would like to point out that this is the column that looks at what definition of futility each of these statements from professional bodies was using. There are different definitions, including some that didn't include a definition at all. So they're talking about futility without actually defining it, leaving it up to the reader to decide which of those three competing definitions is actually being applied. So I would argue that futility is defined by a patient's goals. Aside from physiologic futility, perhaps, which is inability to achieve its physiological, the rest of the futility debate really is about what the patient's goal is. So I think that if somebody were to say to me, is this procedure futile? I would say, well, I think that's actually a bogus question because you can't answer it. You have to know what the patient's goals are. So as an example, if you have a patient who is imminently dying and there's nothing we can do about that, then, and their goal is to go home and lead a happy, healthy life, then I would say that endotracheal intubation would be a futile action. However, if their goal is to live temporarily for a longer period of time in order to allow someone to say goodbye or for them to say goodbye to someone else, perhaps it would not be futile. So the AMA followed up its earlier statement about medical futility by recognizing this. They said that there are necessary value judgments in this notion of futility. So we started off by kind of saying there's futile and there's not, and then the AMA began to recognize that, hey, there are value judgments in this. It lies a little bit in the eye of the beholder. It's largely dependent on patient goals. The other reason, another reason why this attempt to put futility into action failed was because I would argue that we were actually reasoning backwards. And to highlight that, I think that sometimes when we as physicians say something, patients hear something else. So imagine that we say something like, the chance of this treatment working is like 1 in a million. Now, part of that is I think that we physicians are trained not to state absolutes. Like, how often do we say, that is absolutely positively never going to work? Like, I don't think we say that for two reasons. One is we hate being wrong, right? We really like being right and we hate being wrong. And the second reason is you do this job long enough and you will be surprised. The example that always comes to mind for me is I got called for an ethics consult at the University of Vermont where I used to work. And the ICU team was really, really frustrated with this family. They're like, we told this family that this patient is never going home from the hospital. She is going to die here. She will never go home. And they want us to keep going, and they're not listening to us. And I said, well, why do you think they're not listening to us? And the team said, I don't know. Like, we told them the same thing on the patient's previous admission and the one before that, and now they're not listening to us. I'm not kidding. I was like, well, maybe we need to rethink our thought process on this a little bit. So over time, you will be surprised. You'll predict something and it won't happen. So I'm going to give a movie clip. I want to be very clear before I do that I am not comparing patients or families to the characters in this movie, but I do think that there is a lot of wisdom that comes in humor. When we try to sort of dissuade families from pursuing a certain course of action, but they still say, yes, I want that, then we are tempted, I think, to reason backwards. So that logic is rather elegant, which is, according to the AMA Code of Ethics, physicians are not obligated to provide futile treatment. So if I'm able to deem this treatment as futile, thus I am not obligated to provide treatment. So now I've taken the patient and family completely out of it. And now I've said I don't have an ethical obligation, which is one of the reasons some people say that futility is the F word in medical ethics, because it shuts down conversation. It's also concerning about how we as physicians assess futility. So they did a study in the height of the futility movement where they asked physicians, what percentage likelihood of success do you need to have in order to do something? Or put it the other way, what percentage likelihood of success beneath which can you say that's futile? So I'd ask you all this. So if you were to say any chance of success means it's not futile, then what you are essentially is a a physiologic futilist, right? Like, I'm only going to call it futile if it has a 0% chance of working. If you were to give a low probability, 1%, 5%, whatever it might be, then you'd be a probabilistic futilist. And let's imagine that this treatment, all treatments have some downside, but let's assume that it's not incredibly burdensome. So families asking for something that has some degree of burden, not a whole lot, has a low probability of success. At what point would you be willing to say, sorry, that chance of success is either so low or zero that I'm not going to do it? So can't really do this with Zoom, but for the folks in the room, call out some numbers. What do you think? If I were to ask you that question, I realize it's a hypothetical. Where would you draw the line? Recognizing it's a hard question. Any ideas? So Harvey's saying 0%. So he's like, if there's any chance, I'm going to try. Any other ideas? Anyone differ from that? 2%. Thank you. Okay, so let's look and see what they got on this survey. What they found was that about 20% of people are like Harvey. They said 0%. So if there's any chance, I'm going to give it a try. The most common response, about a third of physicians said somewhere between 1 and 5%. Someone here said 2%. So I think we could have a conversation about that. I think we could have a very thoughtful conversation. Where do you draw the line? What are the pros and cons? The concerning part of this survey is the tail. So what this means, according to this, so this is percentage of physicians responding on the vertical axis, and this is what their responses were on the horizontal axis. What this says is that about 5% of physicians said that they would potentially classify a treatment that had a 40 to 60% chance of working as futile. So why is that? Because they didn't want to do it. So what they're doing is they're reasoning backward. They're not saying, is it futile? Thus, I don't have to do it. They're saying, I really don't want to do it. How can I avoid doing it so I can use this notion of futility? And the last thing that stood in our way is implementation. So we can talk all we want about this stuff. We can publish position statements, but when the rubber meets the road in a clinical setting, how are you actually going to do this? We're talking about withholding or withdrawing a treatment that a patient or family is requested, a treatment that potentially is life sustaining, and withdrawing it might lead to a patient's death. And I learned this lesson very clearly at a recent bioethics meeting where I met an ethicist from Texas. And whenever you meet an ethicist from Texas, the first thing you ask about is the Texas Advanced Directives Act. That's kind of what they're known for. And so I said to him, "So, how's the Texas Advanced Directive Act working for you?" This was a few years ago, soon after its implementation. And this is his response: "Well, if you don't count having to move your family to a secure location under cover of darkness, I'd say pretty well." And I kind of chuckled awkwardly. And he's like, "I'm not kidding." Because in Texas they have a lot of guns, and they just because some doctor goes in there and says we're implementing the Texas Advanced Directives Act and we have the legal right to withdraw this treatment, doesn't mean that families are going to say, "Okie doke, I guess you go ahead and do that." They're going to say, "No, you're not going to do that." So, despite all the theory that we could talk about, when it comes to practicalities, there are significant challenges. So this is an editorial from the New England Journal of Medicine talking about the rise and fall of the futility movement. So we weren't talking about it, then we were talking about it, and then we kind of stopped talking about it. So why is that? What happened? First of all, we couldn't agree on the definition. Second of all, even if we had agreed on the definition, we couldn't agree on who should apply the definition. Is it the courts? Is it hospital ethics committees? Even if we had agreed on the definition and who should apply it, we couldn't agree on what to do when people disagreed with that final decision, as my colleague in Texas highlighted. So we gave up mostly and fell back on narrowly used procedural policies. And then you could ultimately say that our discussion of futility was futile, depending on your definition of futility and who applies it. Case closed, it seemed. But then people started talking about it again. So we had this big dip after the fall of the futility movement, and now people are talking about it even more than they were back then. So why do you think we're interested in futility again? Why are we talking about this? Why am I talking about this today? What do y'all think? Say again? COVID. Well, that's a really interesting point. So COVID largely, I think, is a rationing question. So that's an important distinction. So futility is I'm not giving this to this patient because it will not help this patient on some definition. COVID has forced us to confront limited resources, which is this could help this patient, but I don't have enough of this to go around. So those are they're tightly connected, but they're not the same thing. Even before COVID, why did we start talking about this? Social media, absolutely. So all of a sudden, the old days of if a doctor didn't tell you about it, you didn't know about it. Those are over, right? I've had patients come in to me and say, "How about this treatment? Some treatment I hadn't even heard of." So they're finding things. So social media is a big piece. What else? That's a huge one. So there's a huge anti-intellectualism is on the rise. And whereas physicians were used to be known as experts, so you would defer to them, now there's a leveling of the playing field. And other people are saying, "I didn't go to medical school, but I'm pulling articles and I'm trying to parse the literature." And I heard this again from social media. If anyone is interested, there's a wonderful book called The Death of Expertise that came out a few years ago that talks exactly about that. All very true. Another one is money. So we're paying a lot of money for healthcare. So this is the percentage of GDP or gross domestic product in various countries that's being devoted to healthcare. As you can see, we're at the top. This is not a chart you want to be at the top of. And this is at 2014. We are currently, as of 2021, according to CMS, at 19.7% of gross domestic product in the United States is being spent on healthcare. Now, if all that healthcare is helping people, that sounds okay. But if a bunch of that healthcare isn't helping anybody, then why are we spending all that money? I think also there's a bit of a reclaiming on the part of the medical profession. So we like to help people, right? We are doers. We want to make people better, noble callings, but we also recognize that there's a whole lot of stuff that we are not at this point able to treat and not able to cure. And I think that there's a burden that we're feeling because whatever we're doing, aside from that hypothetical scenario that I talked about with minimal burden, there's a lot of stuff we do to people, especially at the end of life, that has a whole lot of burden going on. So are we violating our core commitment to do no harm? And then also, the comment earlier about social media, there are cases that are out there. Many of you probably heard of Charlie Gard, a boy in the United Kingdom who had a condition that was refused. Their parents' request to treat it was refused, and they were advocating through social media, like, why not give my child a chance? So in response to this, there have been some recent consensus recommendations in the adult literature. And so what I'm going to do is I'm going to kind of go through that to update you on that, and then we're going to talk about how to implement. So this is a 2015 consensus statement, as you can see, from a variety of different societies, mostly related to critical care. And I admit that this is mostly focused on ICUs, but there are principles here that will apply in other areas. So they had 4 consensus recommendations in the statement. The first one is to use potentially inappropriate rather than futile. And I think that's a really important distinction. Potentially means I'm open to the fact that I could be wrong. I'm opening a conversation. If I say that that is inappropriate, then I'm declaring something. So this is an attempt to bring people into conversation. I would actually argue that the better term is potentially non-beneficial, because what we're really talking about is overall benefit. So I'm going to use that term as we go forward. So they argued for using the term potentially, I will say non-beneficial. They said that we should advocate for an appropriate treatment plan rather than just laying out a list of options. And they had a process for how to deal with continued requests in spite of the fact that we may have said we recommend this plan if a family said, well, actually, we want this plan. And a lot of these are probably not going to come as a surprise. Expert consultation, give notice that you're going through a process, second opinion, going to a multidisciplinary committee, looking to transfer. And this number 6 is very important because in contrast to the Texas Advanced Directives Act, they don't recommend taking away judicial appeal. So this is not, we're going to keep it all in-house. Families always have the right to go to court. And then finally, implementing the resolution of the process. Consensus recommendation number 3 is that clinicians should not provide quote unquote futile interventions, which they define very narrowly as in the physiologic sense. So they do use the term futile, but only in that one very narrow sense. They also say you shouldn't do things that are illegal. The fourth one is that we should lead public engagement efforts. We should be talking about this. This shouldn't happen behind closed doors. This shouldn't happen in secret. And the last one, which is the one I'm going to spend the most time on, that is actually there first, which is institutions should implement strategies to prevent intractable treatment conflicts, including proactive communication and early involvement of expert consultation. So I would actually argue that if we get to the point of an impasse, maybe we had points along the way that if we had acted differently, maybe we could have prevented the impasse. Because once we get to an impasse, I think that's going to be inherently adversarial. As the old saying goes, an ounce of prevention is worth a pound of cure. So I'm going to sort of talk about prevention as part of this concrete plan. And one of the first things is to get rid of self-defeating practices, which I think invite people to request things that we consider to be either potentially non-beneficial or straight out non-beneficial. One is, and I've heard people say this, something like, as you're going over code status with a patient in the ED, something like, if your heart stops, do you want us to restart it? Making it sound like a dead battery on a cold Vermont morning. And as we all know, CPR is not like that. But even when we do it a little bit better, sometimes we are self-defeating. So do you want us to do CPR? So we ask a question, we get a yes, and then we're like, actually, that's not such a good idea. We're not going to do it. Like, a choice is only a choice if it's a choice. And potentially I'm guilty of this too. Just look at the title of my talk, responding to requests. Like, I kind of set myself up just with the title of the talk. So George Harrison once said that since our problems have been our own creation, they can also be overcome. So I'm going to put forth a concrete plan because I've been to a whole bunch of grand rounds in my life where somebody gets up there and says, here's the problem. It's a really tough problem. And then they end. And I hate those things because I'm like, I knew it was hard. Now I just know it's harder. So we need to have something that we can take home from this to be like, and also something you can choose to disagree with that we can talk about rather than just kind of casting it in broad strokes. So here are some steps to prevent quote unquote futility conflicts. The first is, everybody always asks, what's the law say about this? So obviously different states have different state statutes and state case law. But in general, if a family sues to keep a treatment in place, if we say, hey, we want to stop that because we don't think it's beneficial, usually courts will give them at least a temporary stay. Now, it takes a lot of work to get there, but it's also not very hard to understand. Like if I'm a judge and I want to be a judge, I probably didn't think of me being a judge that would involve looking in the eyes of a grieving family who are begging for one last chance for their child and having the doctors on the other side not being willing to say it's not going to work. The doctors saying it's highly unlikely it's going to work, and me taking that hope away from a family. Like that's just not what judges do. However, if a family sues after the fact, generally speaking, of all the court cases that have been brought up, almost always the courts will side on the side of the hospital as long as there's been due process. We've gone through the steps, and as long as the physicians and team involved haven't been callous. All right, so a lot of things here. Steps to prevent futility conflicts, 2 don'ts, 8 do's. One is don't dwell on non beneficial treatments. I'm amazed at how often we tell patients and families what we're not going to do. Like if you think about it, with every patient, just think of any patient, there's a whole lot we're not doing for that patient, right? Like whenever a patient says, I want everything, I think to myself, oh gosh, you really don't want everything. Like, can you imagine if you got everything that we could do? And so what we end up doing is we focus on the negatives. So, like, just think of the limitation of treatment orders that we have. Do not intubate, do not resuscitate. I've had situations where I've had families look at me and say, you guys keep talking about all the things you're not doing. Are you actually going to be doing anything for my kid? I'm like, yeah, we are doing a ton of stuff. So rather than focusing on the negative, I think we need to focus on the positive. We also have to be very cautious as we go through this when we decide what not to do, that we're not falling into the trap of what I mentioned before as qualitative futility, which I think is just a bald quality of life judgment. And as soon as I start thinking, or someone starts thinking, well, what kind of quality of life does that patient have? We need, I think, to reel ourselves back in because studies are replete with evidence that physicians underestimate quality of life. So if you look at a family and a patient and you ask them what their quality of life is, they'll almost always say it's higher than we think it is. The other is don't use the F word. So we might think we know what we mean by it. I would actually argue that we probably don't know what we mean by it because we mean so many different things. But even if we're using it technically, even if we've read this consensus statement, even if we're using it in a physiologic futility sense, I don't think it comes across that way. If I say something is futile and I'm a family and I hear that word, I think I hear it's not worth the doctor's or the team's time or effort to help my kid, which is not what we mean and clearly not what we want to express. So those are the 2 don'ts. What are the do's? Do clarify patient goals. So I think that sometimes we reduce conversations in a very practical way to procedural conversations. And I understand the motivation. Like, especially if you're a resident, you got a lot of patients stacking up, you need to know what a code status is. It's a lot easier to sort of talk about CPR, intubation, ICU transfer than it is to talk about what are your hopes? What are your goals? That opens up a long conversation, it requires nuance, it requires skill. And I'm not expecting us to do that every single time, especially when time is tight and we have a lot of other patients calling for our needs or their needs. However, in an ideal world, and this is where hopefully in the light of day when the dust settles, we can do this, or you have an awesome palliative care team like you have here at Lucille Packard, can do this to identify what the patients and families' hopes and goals are. And I will tell you the number one question I ask families when we do a palliative care consultation is, what are you hoping for? And I can tell you, based on their response, is that is often the first time they've ever been asked that question. They kind of look at me kind of like, are you really asking what I think you're asking? I'm like, yeah, I really am asking what you think I'm asking. And then we get into this long conversation. So don't have time to go into this in great detail. I would encourage everyone to take a look at this. This is what's called the Serious Illness Conversation Guide that's coming out of Ariadne Labs, which is Atul Gawande's operation in Boston in concert with Harvard Medical School. This is how to have serious illness conversations. The point that I would identify are these 6 things. And what I do when we have learners come through with our team at OHSU is we actually role play this. And I tell them, I want you to have a conversation with somebody that one of our team members will role play. I want you to have a conversation. Imagine that we are a parent and you're not allowed to use any medical terminology whatsoever. Can't do CPR, can't talk about intubation, dialysis, antibiotics, can't do any of that stuff. It has to be a human conversation. And what I want you to do is I want you to identify these 6 things. So, and 2 of them are flips of the other. So hopes is what you hope will happen. Fears or worries is what you hope won't happen. Those are flips of each other. The next 2 are critical abilities, otherwise known as what makes life worth living. And then the Related thing is trade-offs, which is what you're willing to go through in order to get those things, how much suffering or burden or risk you're willing to undertake. The fifth thing is going to be where your sources of support come from or sources of strength. And the last thing is actually kind of a gimme in pediatrics, which is family involvement. In adult world, you have to ask. In our world, oftentimes it's self-evident because you're already talking to families, so you kind of get one for free. You only have to do five. And then I say, after you get your five, I want you to make a recommendation of a treatment plan. So that's the first time you're allowed to use any medical terminology. Up until then, it's just been a human conversation. So I want to be clear. I recognize this takes time. Sometimes takes a lot of time, takes place over multiple conversations, but the investment of that time at the beginning is going to pay off huge rewards at the end. So now that we've identified those goals, we can make a recommendation based on those goals. Now, that may come, especially to some of the younger folks in the room, as a bit of a surprise. Like, we have elevated patient autonomy or family autonomy to an incredibly high level in our society. And I still remember when I was teaching ethics back at the University of Vermont, like first week of medical school, I would say to medical students, I say, you don't just sort of lay out a bunch of options. I said, you make a recommendation based on your medical perspective on what the treatment plan should be. And they kind of looked at me like, should he really be teaching ethics at a medical school? Like, that doesn't seem to really respect patient autonomy. And I'm like, hold on a minute. This isn't what I think you should do. This is based on the goals, the hopes, the fears, the trade offs, the critical abilities that we just identified. Now I know what you as a human being hope for your child. Let me use my medical perspective and experience to tell you this is how to get there. An analogy I often use is parents are the captains of the ship. They get to tell us where we're supposed to go. We're the navigators. We're supposed to tell them how the best way to get there is. So I don't think this is paternalistic. I actually think this is very patient centered and patient respectful, but it requires that preliminary work to be put in. Do consider burdens as well as benefits. Anyone who's worked in medicine knows there's a lot of burden involved in the treatments that we provide. And the burden might be like physical suffering. One of the reasons why we do symptomatic management, especially in ICUs for patients who are intubated and things like that. It might be lost opportunities, like kids who are in the hospital aren't out doing what they would otherwise be doing. They may not have the ability to experience the things they're experiencing. They may not have the family time that they would wish for, all that kind of stuff. So if all we focus on is likelihood of efficacy, we miss the fact that everything is a trade-off in life. So I think we need to be clear that there are burdens as well as benefits in what we talk about. I would argue too, we have to reframe the default. So I can't believe how many times I've lost count that I've said to families or patients, the default value in medicine is that we do everything for everybody all the time, unless there is a conscious decision to do otherwise. And the more I say that, I'm like, I'm not sure I agree with that. Like, I observe it to be true, but should that be the case? And so there's been provocative work done in the medical literature to say maybe we need to reframe the default. Because from a social psychology point of view, the default is inherently viewed by the person who's hearing it as an acceptable option and maybe even the preferred option. So if I say, unless you decide to not do this, we will do it, it feels very close to me recommending that we would do it, or at least saying that it is perfectly appropriate for you to do that. So maybe there are certain situations where full treatment should not be the default. Blinderman and colleagues published a very provocative article in JAMA about 10 years ago where they said this whole notion of full code being the default, maybe that shouldn't be the default. Maybe there are certain situations where the default should be DNR unless there's a decision otherwise. Maybe there are some situations where there isn't even a possible decision otherwise. So I think how we frame defaults is going to be important. We should utilize informed non-dissent. Some people call it informed assent. I think informed non-dissent is a more accurate term. So when we think about how we present things to patients, I think oftentimes we present what I say sort of whimsically as a dim sum approach to medical decision making, which is here's the menu, you choose what you want. You know, if you want some dumplings, you can have that. If you don't want, the sticky rice, you don't have to have that. Same thing when it comes to CPR, intubation, dialysis, or whatever. There are two big problems with that. One is it comes up with nonsensical treatment plans. You have patients who are like, well, I don't want to be intubated, but I'd like CPR if my heart stops. Well, that's a dim sum menu approach. It doesn't really make medical sense. The other problem with it is that it isn't something based on their goals and maybe based on the fact that it's really, really hard, especially for a parent, to say, no, don't do that thing for my kid if it has a chance of working, even if they think it's the right thing to do. So you may think this is a semantic difference. I actually think it's not. I think this is a substantive difference. So just imagine the difference of the questions. Let's talk about CPR. So I don't think we should do CPR. So I would, what do you think about CPR? I think that we should probably not do it. And what I'm doing is I'm asking that family to say, no, do not do this for my kid. Compare that to something along the lines of, based on what you've said and your goals, I don't think CPR will help your child and your family achieve your goals. So we are not going to do that unless you object. So notice the switch. So instead of asking them to verbalize, no, don't do it, all they have to do is accept my recommendation. So in retrospect, they are free, which I'm inviting them to do, say, well, the doctor recommended that and I just didn't object. So now we've reframed the default, haven't we? Which I think can be really, really important. It's also important to note that I said, unless you object, right? So I'm not taking away rights. I'm not going in there unilaterally. I'm just saying, I'm willing to take a little bit of this burden on me in order to spare you from carrying all that burden on you. So I think that how we frame that can be really important. Do offer a time limited trial. Some people call it a TLT in the literature, or provisional intensive care. And what that does, I think, is it reframes the question from a binary. When we talk about a treatment, antibiotics, CRRT, whatever it might be, when we talk about a treatment, sometimes it gets reduced into a binary. Do you not do it ever, or do you do it forever? And that's not the way medicine works. Like, not doing it ever is a decision. But when we start something, we always start it and we're always thinking, is this working? Is this achieving the goals that we have for this patient? So, what we can do is if a patient or family is asking for something that we're like, I'm not sure that's such a good idea, rather than kind of draw our line in the sand, we might say, well, why don't we try it? Like, maybe I'm wrong. Like, I've been wrong lots of times in my life before. I'm willing to accept that fact. Why don't we try it for a period of time? Now, that period of time has to be long enough for that to potentially provide benefit. Doesn't make sense to say, well, why don't we intubate and see how he's doing in an hour? Most likely, that's not going to be enough time to have benefit. But it shouldn't be so long that we will have long ago found out if it's beneficial and then still have to keep going. So, what would it look like if I were to say, okay, well, why don't we try it for a period of time? And I lay out the period of time, 72 hours, a week, 2 weeks, whatever it might be. And say, why don't we come back at the end of that and see how things are going unless something major happens in the meantime? So that does a couple of things. One is it sets up a clear sense of we're going to come back and talk about this. So when I come back and talk about it, no one's taken by surprise, which I think is a really important thing to do in this situation. And it also allows me to say, why don't we talk in advance about what success or failure would look like? So these are things that would make me think this thing is working. Maybe more stable blood pressure or lower FiO2. These are some things that would make me think this isn't working, like unstable blood pressure, need for pressors, or whatever. So along the way, the family can be aware, like, hey, this is going in a good direction, or it's not going in a good direction. And if it's not going in a good direction, and I come back at the end of that period of time, I don't have to prep them for it's not going in a good direction because they will have seen that. Now, to be clear, this is not a binding agreement. It's not like we're going to come back after 72 hours and say, not working, we're going to stop. But what I've done is I've sort of hopefully prepared the family for a thoughtful conversation based on what they were willing or led to expect. Consider a do not escalate treatment order. So rather than saying stop, maybe we could say, let's just keep doing what we're doing and not do anything more. Because then, if the patient requires more to survive and they don't survive, it's very clear to the family that it's the patient's worsening condition that led to their death and not some conscious decision that the family made. Now, that sounds really nice and neat. Unfortunately, in practice, it's not very neat. Because if I were to ask you certain things on whether they constitute escalation of treatment, like I'll just do it. If a patient's not on pressors, do you think adding a pressor would be escalating? A really simple question. I realized, yes, that's a yes. That was, don't overthink it. So, what about if someone's on pressors and they need a second pressor? Is that escalating? Is there a little pause? What about if someone's on 40% FiO2 and they have a little DSAT and they really need to dial up the O's to 60%? Is that escalating? someone said that was a longer pause. Um, Technically, according to the definition of the word escalate, I would agree that is escalation. Do you think that's what the family was envisioning when we said we're not going to escalate treatment? I think they were envisioning not doing more stuff that's burdensome to my kid, not just dialing up the O's for a mucus plug. So I think that it sounds really good, but it requires us to use a lot of discretion. So a couple of don'ts, 8 do's, or almost 8 do's. So what we've done so far is that stuff has been shown, according to studies, to resolve most quote unquote futility conflicts. But what if, despite all those thoughtful steps that we've done, we still get into an impasse? And that leads us to the extreme cases. So you've done everything really well. You've tried to prevent it, tried to educate, talked about hopes, fears, goals, etc. Family still says, I want this. And you think this is not a good idea. Not going to help this kid. It's potentially going to hurt this kid. I think you have two choices. One is you could unilaterally forego the treatment. You could be like, no, I'm just not going to do that. And there are reasons for that. Some people talk about our need to prevent suffering as being a specific calling, which is true. Like not non-maleficence is an important thing that we do. We shouldn't cause harm. And then people have used the term dyskinesia as essentially causing increased suffering. We talk about use of resources. The COVID issue was mentioned earlier, and we talk about professional responsibility, and that's an AAP statement. So certainly we don't want to hurt anybody. And so we could just say, sorry, we talked about this. I just can't do this. Or you could provide that non-beneficial treatment that you think is non-beneficial. And there are reasons for that. One is we could be wrong. Another is maybe it's a value conflict as opposed to an empirical conflict. There may, and this is a whole other thing we could talk about, maybe patients who are beyond suffering. Like when people say that, the pain is in your head, I always say pain is always in your head. That is actually where we process pain. So maybe someone has such degree of neurologic trauma that they can't experience pain. And there's also concern for discrimination about who we say, no, we're not going to do this. And going back to Texas, it's interesting to note that the vast majority of kids, especially in Texas, who have had treatment withdrawn based on the Texas Advanced Directives Act, have been members of minority groups. This is a bigger topic, but I always come back to a very powerful op-ed written by Bob Trug, who's an intensivist and ethicist at Boston Children's. And he tells the story when he talks about whether it's wrong to perform futile CPR of a patient in his ICU who was dying of cancer. And everybody knew he was dying of cancer. And they had had all these thoughtful conversations with the family. And they had said, we don't think we should do CPR. We think we should redirect care, focus on comfort. And the family's like, we are not going to let our child go. We are hoping that he can still recover. We need you to do everything. Absolutely constant about that. To the point where the nurses were experiencing extreme moral distress. There were ethics consults called. This was causing a huge amount of understandable angst in their PICU. And then one night, this patient arrested. Family was not there, and they performed a full code on this patient. We're talking about chest tubes for potential pneumothoraces, central lines, CPR, everything. And after about 45 minutes, they called it and declared the patient dead. And then the family was on their way. And they tried very hard to clean the patient up, but there were still all the signs of where the chest tubes went in, et cetera. And they didn't know how the family was going to respond to come and find their child who had died. And this is what Trug says. What surprised me the most when the father gently opened his son's shirt, revealing all the puncture wounds and bruises from our failed attempts to place a subclavian catheter. He looked up at me and said, I want to thank you. I can see from this that you really tried. You didn't just give up and let him die. And Trug goes on to say, although the interests of the patient are always primary, at the end of life, there are times when the interests of the patient begin to wane while those of the family intensify. Family members may live for years with the psychological after effects and regrets of end-of-life decisions. By sometimes agreeing to provide futile CPR, we send a message to our communities, not that clinicians can be bullied into performing procedures that good medical judgment would oppose, but that our hospitals are invested in treating patients and families with respect and concern for their individual needs. Now, I want to be really clear. There are a whole lot of letters about this article in the New England Journal, and a whole lot on one side and a whole lot on the other. So I'm not saying this is the truth. I'm saying he said this. I find it profound. A lot of people disagree. Last point. The last remaining middle ground is what some people call tailored codes. So some of you may be familiar with the notion of a show code or a Hollywood code, where someone you don't actually push on the chest and you don't really go actually do anything that's helpful, but you make a show of it in order to appease a family who say they want that you make them think you've done something that you actually haven't done. Clearly unethical. There's consensus in the literature on that. This is different. This is not a slow code where you sort of saunter to the bedside and don't do much. Some people would call this a fast code. So the critique that some might have of the Boston Children's team is not that they attempted to resuscitate this kid, but they did so for 45 minutes. So there may be situations like the purpose of a resuscitative effort is to restore spontaneous circulation. You may not require that much time to determine that that is not possible. So again, this is a situational, contextual thing. Like, what do I need to know in order to say that this is not working? I'm willing to accept the fact I could be wrong, but when I have further evidence, maybe that proves that I wasn't wrong about the efficacy of this intervention. So in summary, let's try to prevent things before they become conflicts. And here are some ideas that we can talk about: time-limited trials, informed non-dissent, do not escalate treatment orders, and tailored codes. I want to be really clear, this is not a magic formula. If you do all this stuff, it doesn't mean that you won't reach conflict, but hopefully it will reduce it. And along the way, we'll have a better sense of patients' and families' goals and fears in order to take better care of them. We have about 5 minutes for questions, which I would very much value. So thank you all very much for having me here today.
Great talk. Um, where do you go through your do's and don'ts when it's compounds, agents that don't have INDs? So we're increasingly seeing families that want drugs that have never been tested. They don't have an FDA approval. They don't have an and they want us to obtain an IND. That's, I don't know if it fits through the do's and don'ts.
Well, I think that fits. Oh, yeah, of course. So the question is, what about INDs for drugs that have no real data associated with them that parents are asking for? So those three types of things that I talked about at the beginning, we were focusing on things that are almost certainly not going to work and have burden. That's sort of the one you're talking about is category 2, which is absence of evidence and evidence of absence. Like, we don't know if it's going to work or not. We also don't know what the harm to do with that is. I think those are difficult situations. It's really kind of the Charlie Gard situation too, for those aware of that. So it was unproven treatment, but we didn't have any other treatment. So I think there are a couple of things to say. One is, are there any treatments that we do have evidence for? To the degree to which can we infer anything about the likelihood of benefit? I actually think in situations like that, that we have greater latitude to decline if there is any other possibility of success. At the same time, if we think that there's a reasonable safety profile out there, even if we don't have efficacy, we might be willing to do that. A colleague of mine at Johns Hopkins told the story of a patient with almost the same condition as Charlie Gard, whose parents were demanding something that was entirely unproven, and she was like, "I'll just do it in order to let them know that they had tried everything. I know it's not going to work." And then she watched her patient improve on it. So I think that we have, especially if there's safety concerns, I think we have right to decline. I think that if we have decent safety understanding, then at least trying, as long as parents understand what the sacrifice is and what they're losing in that in terms of a focus, I think we might want to think about that.
Okay, I have a question from Alexis Davis, one of the superb neonatologists. Sometimes we try the dialogue of potential continued pain and suffering at the expense of continuing intensive care efforts. Parents request that we simply provide for analgesia, leading to a near comatose state in perpetuity and moral distress among medical staff. How can we avoid this quandary? I would like you to think about, while we do these things to the families, what does this do to us as the caregiving team? I know, sorry.
2 minutes. I think that's an incredibly hard question on 2 levels. So one is, what does it mean for quality of life? I just got done talking about quality of life and how we physicians tend to underestimate. At the same time, permanent comatose state, it's a hard argument to make that there's really any quality of that. There are certain religious and cultural belief systems that believe that any life is better than no life. But if you don't believe that sort of binary, then it's hard to imagine that. I think that in situations like that, we sort of have to figure out, like, when someone's like, there's so much suffering, my first question is always, well, who's suffering? And there's lots of potential people who could be suffering. Patient could be suffering. Family is clearly suffering in grief, and they're searching for what to do what's right. And there's also our suffering. And so I think identifying whose suffering we're talking about is important. And I think that we have, even though I'm not a big fan of futility policies, when you sort of, at some point, you either have to say there's never ever going to be a situation where we unilaterally decline. But if you open up that door, which I think it deserves to be opened, a state of maintaining permanent unconsciousness is a situation that I think falls even below my kind of open-minded view of what quality of life would be. And if we're talking about that, then I think we need to sort of either think about how to reframe the conversation, especially when it comes to other things that will come up. Most times people aren't just permanently unconscious. They have things that come up. There are infections, there are complications. Is there a way that we can reframe it to say, let's keep doing this, but we're not going to escalate, as in the do not escalate treatment? So there are ways around that. And the whole notion of how we as a medical community deal with suffering is a whole other question, because I think that our spirits are tired. They were tired before COVID, and I think they're exhausted now. So how we support each other through that is a big question.
I have one request to think about palliative care and elsewhere. Anecdotally, when I met with families after the death of their child, and where there these been issues of requesting treatment that people might have felt was inappropriate, I've hardly ever been in a situation where the family said, you know, we shouldn't have done that. They almost always say, well, we did everything we could to try to save, and you did everything you could to try to save my child's life. I would actually love to see some research done in a more formal way to see, are we really helping the families, or how are we helping the families by doing the things you suggest, which is if they request it and it's unreasonable to do it, even though you don't think it's going to work, or are we really hurting them? Because people say to me sometimes, well, we're really doing this for the family, so they're not going to suffer anymore. We're going to let the child die. And my counter to that is I really have not seen that as being beneficial to the family.
I hear that. There is some earlier data. Joanne Wolf and some of her earlier work at the Boston Children's did some retrospective studies where she asked families of deceased children, what was your goal as your child was dying, and what do you wish in retrospect your goal had been? And a significant proportion of patients or families who said, our goal at the end of life was to perpetuate life, now look back and say, actually, I wish it had been more on comfort. At the same time, it's a bit of a selection bias because it's families of patients who died. Like there may have been some families of patients who ended up surviving because of that treatment. So I think that that's an important thing to identify. And also, if done in this thoughtful context, we're already limiting on some level. Like we're not bringing out, we're not saying things like, well, I guess we could do ECMO, but I don't think we really should do ECMO. Like if we're not going to do ECMO, we shouldn't talk about ECMO. So I think that if we move away from that, we're going to lay it all out there. We're already trying to be a bit protective and limit what the options are.
Well, thank you.
Thank you all very much.
Thank you all. Thanks so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.